Hi everyone, welcome to session 116 of the Behavioral Observations podcast. Today's show is brought to you by Behavior University and GoLotus. Behavior University's mission is to provide you with university quality continuing ed. So if you're in quarantine like I am, take this time to brush up on your skills or push yourself to learn something new. For great deals for podcast listeners, head over to behavioruniversity.com/observations to learn more. GoLotus. GoLotus recognizes that ABA providers are facing their most difficult challenges right now. So in light of recent events, GoLotus has decided to open up its data trackers and scheduling systems for nearly 90% off to help everyone make it through these challenging times. Normally $40 a seat, GoLotus will offer these services for just $5 a seat for all new customers until this crisis ends. Trust me when I say that they are not looking at the pandemic opportunistically. GoLotus was founded by a mother of a child with autism, and she wants to make sure providers have the tools necessary to serve their clients, even in the face of economic hardships. So for more information, please check out GoLotus.com and request a demo today. All right. This episode is a rare replay of a podcast session that was apparently ahead of its time. Back in session 26, I interviewed Dr. Wendy Machalicek about using telemedicine in the context of ABA service delivery. At the time, she was one of a few behavior analysts conducting research in this area. Once this current pandemic went into full swing, I gave the episode a re-listen and found that many of the lessons Wendy imparted are still quite relevant today. So rather than reinvent the wheel, I decided to republish the show. I'm happy to produce more content in this area, so if there's something you're interested in this realm of telemedicine, please leave a comment in the show notes for this episode or on social media. I'm on Facebook, Twitter, LinkedIn, etc. At the same time, I know other ABA podcasters, CEU providers, and the like have created many offerings in the realm of telemedicine, so I'm just as happy to continue pursuing other topics of interest. Long story short, just let me know your thoughts either way. All right, and lastly, I'd like to draw your attention to the recent issue of the Journal of Behavioral Education, which put out a special issue on telemedicine. I think Wendy might have been one of the editors of that issue. And then Behavior Analysis and Practice is also pumping out a lot of content to help providers in this kind of uncharted territory. So I'll have links to that stuff in the show notes for today. And again, with regard to this particular episode, I just want to let you know that I kind of just deleted some of the stuff from the earlier version of the episode that was published a few years back. And so we just start off right into the telemedicine stuff. And if you want to learn more about Wendy's background and the state of ABA in Oregon, you can certainly go back to the original episode, and I'll have a link to that in the show notes too. But we're just going to, cut to the chase, and there will be no commercial interruptions in this broadcast. So I hope you enjoy this conversation and find it as informative as I did. So without any further delay, let's hear from Dr. Wendy Machalicek.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
All right, so let's get on to the general topic here. You were kind enough to send me some of the articles that you have written on telehealth or telemedicine, but I guess the one starting point would be just to kind of lay down some operational definitions, if you will, of what this means. So if someone is tuning into this podcast and have never heard those terms before, what is your working definition of telehealth or telemedicine, or what if there's a different term that you use to describe these practices?
Mm-hmm. So in our research team, we've used a variety of terms, but we've kind of settled on telehealth as the terminology that we've been using. And really, I just define telehealth, and other professionals have defined telehealth as two-way communication between a clinician and a client, or two clinicians in regards to a client. It can be asynchronous or synchronous, but through the use of telecommunication technology. So it could be through Skype or VC, so a video conferencing software, or it could be simply through a smartphone, which, maybe you use an app for that, or you're using Google Hangouts, or it could be, store and forward kind of technology where the family actually uploads a video of their interactions with their child to a HIPAA-compliant cloud-based software, and then you access that and you give them a telephone call. So there's a lot of different softwares and tools and ways of doing telehealth, but it basically means enabling communication at a distance between a clinician and a client or patient, or two clients and a patient. I'm sorry, not sorry, a client and a patient, or two experts and a patient.
I see. I understand.
Yeah. Sorry.
No worries. So as it relates to, I'm assuming this is somewhat new in the world of behavior analysis. Has it been used? What's the history of this work in other disciplines or professions?
Yeah. So basically, if you Google any medical issue, so cancer, chronic illnesses, so cancer, diabetes, heart disease, or any acute issue like emergency medicine kind of things like head trauma or dermatological kind of exams, you will find tons of telehealth research. So the medical field and the public health field they're really light years ahead of education or in behavior analysis in terms of where they are with researching telehealth methodology and looking at effects of telehealth. But increasingly, behavior analysts are using telehealth in our practice, in our research. Since 2006, we've had a growth of telehealth research. Dave Wacker's group was one of the first ones. We were one of the first ones at UT Austin to start using telehealth, and usually really using either more advanced forms of telehealth, like with fiber optic cables and hospital networks, or more consumer ready software and materials like laptop computers and Bluetooth headsets and webcams that are connected to that laptop externally. So, it's been used across medical and public health professions, psychiatry, psychology, and it's moving into education as well. So it's been used in school settings as well, increasingly so.
So as it relates to behavior analytic interventions, what are some examples that you have seen that work well for these types of applications? What sort of interventions have been done in this manner? And certainly feel free to discuss anything that you studies or projects, et cetera, that you've been involved with.
Yeah, so telehealth has been used to do functional behavior assessments, to do experimental functional analyses, to conduct preference assessments in natural settings, all of those assessments. It's been used to deliver discrete trial training, behavioral consultation to families, to teachers of children of all ages. And increasingly, it's being used in the typical school population as well. So thinking about struggling readers or kids that are struggling with math or teachers that need to deliver specialized instruction, it's being used in the school systems in that way as well. So increasingly, it's being used to leverage that use of that technology in different ways. So initially, the field we kind of started out as saying, can we do this? Can we use this consumer-ready technology that we used to call up grandma and grandpa on the weekends for our kid to say hi? Can we use that to now deliver interventions and to deliver those to people with disabilities in their homes, with their natural caregivers being the interventionist, or sometimes having like an RBT be the interventionist? And we've basically answered that question, I think, and we are starting to leverage telehealth in a slightly different manner. We're starting to use telehealth to address issues around low incidence disabilities. So some of my work recently has focused on assessment and treatment of challenging behavior for children with Fragile X syndrome. And one of the issues that we came across in my collaboration with folks is it's a low incidence disability, and it's difficult to even get enough participants for a randomized control trial. So we run into some issues around recruitment and the cost involved of having people participate in those studies. And so we started to use telehealth as a way to reach an increased number of participants for that kind of research. But also along the way, we found that it's very useful for a primary service provider model. So for interdisciplinary collaboration. So let's say a BCBA is called in on a case where they're addressing challenging behavior. They conduct the experimental functional analysis. And then for the intervention, they work alongside an SLP to select an appropriate MAND for that reinforcer that's maintaining the challenging behavior. So we've been able to use telehealth in some slightly different ways than we have before. One of those is low incidence disabilities. And then, as I mentioned, reaching additional parties. And so part of that is in rural areas and for folks with disparate access kind of issues. So whenever there's shortage of specialists in rural areas or otherwise, like in the state of Oregon, where we simply just don't have enough BCBAs, telehealth is being used to provide supervision to our clinicians on site, and to provide services to families and to individuals with disabilities who typically would not receive those services. The same goes for teachers. So teachers in rural school settings often don't have access to the same specialist support, and telehealth is increasingly being utilized in that manner. So, for example, one of our recent studies with Andy McDuffie at the Mind Institute looked at delivery of a communication and behavioral intervention for adolescents with Fragile X syndrome. And it was parent implemented. So it was a parent implemented intervention that focused around shared book reading. And so they were focused primarily on language targets, but the BCBAs provided consultation at the same time during conjoint telehealth sessions around managing challenging behavior. So an experimental functional analysis was done, a functional behavior assessment, of course, prior to that, and then development of a behavior support plan that could be used within the context of that shared book reading intervention. Then the BCBA and the SLP could both be present on the telehealth call with a family member who was at a different location. So oftentimes we had 3 different calls initiated at once, with the BCBA being in Oregon, the SLP in California, and the family member somewhere else in the United States.
Wow, that's incredible.
Yeah, it was pretty cool to work on a team and to think about how behavior analysts can do some crossover in terms of role release. And some of that primary service provider model is not part of our training as behavior analysts often.
So with regard to the study with trying to get enough participants for investigating issues with individuals with Fragile X, it sounds like telehealth was was a tool to conduct that research because to mitigate the costs associated with bringing people into a clinic and things like that. So it's kind of interesting because originally when I kind of thought about this interview and some of the research that telehealth was investigating the role of telehealth, and then this is kind of like sounds like the other way around. And I guess I had it backwards, and there's just a tool to help implement some of these investigations and things like that.
No, I mean, sometimes we are focused on, is telehealth an effective mechanism for delivering behavioral consultation for families that otherwise cannot participate in face-to-face interventions, or how does it compare to face-to-face interventions? So we are very much interested in that. The flip side of that, though, is that it is a really cool technology that you can use to deliver interventions at a distance that you typically cannot face-to-face. So if you think about, for instance, the functional behavior assessment of infrequently occurring challenging behavior, that's a difficulty, right? We go into someone's home and they say, well, this is a really serious challenging behavior, but it only happens once a month. I can't quite predict it. The scatter plots don't tell me when it's going to happen. Telehealth provides us one way to actually say, why don't you just give me a call when it happens? Mm-hmm. And I can take a look at that behavior. So we've been able to kind of covertly address some issues with adolescents in particular who are more aware of their surroundings and they're more aware of the technology use by hiding some of that from them. And so it's kind of covert that you were observing their behavior at times, with parents' permission, of course, so their guardians' permission. But
that ties into a question I got from a listener, and so if you'll indulge me, I'll read it because it kind of addresses this a little bit, or at least it's a kind of a piggybacking question. So Diane asks, I want to know if Wendy has had success with using technology to reduce observer effect during observations or assessments of behavior. This person provides home and community-based services to adults, and those observer effects are one of the biggest challenges she's having she's had difficulty directly observing problem behaviors to conduct a valid analysis.
Mm-hmm. Yeah, we stumbled across this effect. I guess you would say it's a positive side effect, but we stumbled across this in doing telehealth sessions in our research because we noted that some children were reactive to the technology, and we would cover the camera with a piece of paper, and we would use iPad cases that would flip open so that the screen would not show, and we would hide them. So we would sort of strategically place them in the room, the parent would, before they brought the child into the room. Then they would do some sort of neutralizing routine with the child, like blowing bubbles or something else that was preferred. And then they would transition into whatever we were going to do for the assessment or intervention. And so oftentimes, in particular with children who were adolescents with Fragile X who had heightened social anxiety, we would hide the presence of our interventionist or our assessor through the use of technology. So we kind of stumbled upon that within our work with that population, but have continued to use that kind of strategy to minimize disruption and to decrease any sort of social anxiety or observer reactivity that we find. So we have found that to be extremely useful for individuals who are reactive to having an observer in the home, where you have that child who acts perfectly behaved and, until you turn the camera on. And then or until you turn the camera off, rather. So the parent says, oh, they're acting really, they don't act like this usually. Usually they throw a huge tantrum during dinner.
Oh, yeah.
It enables you to capture that in real time. And if the parent is wearing a Bluetooth headset and is able to cover their ear so that the child doesn't know, you can really direct the parent's behavior without the child being aware. Now, there are some ethical issues there if you're working with adults in particular in terms of assent for that kind of procedure and consent as well. But I think it has great possibility.
I see. So that kind of leads me into a subsequent question. As I have to confess, I love gear.
Yeah.
I don't know. I have trouble mastering it. Its use. But I always love talking about this kind of tech stuff. So let's talk about. You talked about a Bluetooth headset. Let's go through kind of a list of the
Sure.
types of things that folks need if they were thinking about doing these types of interventions in a telehealth model.
Yeah. So I'll just set aside the ethical issues and confidentiality for a moment and talk clearly, just primarily about the gear. So
we'll come back.
Yeah.
To that.
So the basic gear that you need is a laptop computer or a smartphone or a internet-enabled tablet. So on the provider side of things, you need that. And on the parent side of things or the client side of things, you need the same equipment. So you need a laptop computer, an internet-enabled tablet, or a smartphone. So there are some confidentiality concerns with the use of a smartphone that you can get around with use of a tablet or a computer. So in our research, we've primarily used tablets or computers. You need to have a video conferencing software. So if you're going to do synchronous visits with that video conferencing software, you need a HIPAA compliant video conferencing software. We've used VC most often. And then you need a headset of some sort. So like we're using headphones right now where we're talking to prevent some audio feedback. That's something that's very helpful for parents and other clients. I like to use Bluetooth headsets. They're a little more expensive, but they enable the parent to hide the technology from their child. And you prevent, since I work in challenging behavior, I'm thinking a lot about dangling cords and children might grab it and hurt the parent. And so we try to minimize the amount of equipment that is accessible to a child. We've often, in our own practice, we've used external web cameras on the parent or client side of things to enable us to get more of a bird's eye view. So really to enable us to have more visualization of the assessment or intervention area so that if the child runs out of the area or the parent needs to stand up for whatever reason, they're still within our field of view. Whereas whenever you're doing Skype to Skype with your family member or a colleague, we're usually sitting down or standing, but we're right in front of the computer screen. I find that to be effective for didactic education sessions, for discussion kind of questions, for greetings and endings of your video conferencing sessions. But once things are up and moving and you're actually doing behavioral skills training with someone, or you're coaching them through a routine, then I actually need them to be able to move around. And so we tend to use a external webcam that's connected to a laptop or an internet-enabled tablet. We've also used some of those flippable, they're called clam cases. So we've used some, they're very expensive, but dear to our hearts. They're flippable iPad cases. And so they're actually really great about angling it. So if you put it up on a bookshelf or a dining room table, you can angle it in such a way to get a bird's eye view as well.
Oh wow, that's pretty cool.
Yeah, that's kind of low tech though. So whenever you really look at the gear that's available, you can use remote cameras that you can move. So Stephanie Peterson's group out at Western Michigan University, they've used some really cool sort of movable technology for those web cameras for work with teachers. So teacher consultation, and of course, big in the teacher education world is this thing called Swivel. So it's actually a remote unit that you can control remotely and actually move it around to capture the teacher's instructional behavior better.
I see.
Yeah.
So this kind of feeds into another listener question. Geeta, who is from India and is obviously very curious about delivering services in remote areas, had a question about the kind of the parent training piece. What obstacles or barriers, if any, have you had as it relates to parent training for these types of using this type of equipment? I know, for someone like myself who's can kind of geek out on this sort of thing, I would be like, yeah, let's do this, but I can imagine, I have just as many, colleagues and friends who are, kind of who are more on the Luddite end of acceptance of technology and things like that. So can you talk about how that works?
Yeah. So, I think to a certain extent, families that participate in our research or that uses telehealth technology are self-selecting, and they're definitely not fearful of technology. We have some families that are a little concerned about their technology use. We've put in place some really specific educational pieces like videos or step-by-step task analyses that tell you how to set up everything. We also try to set up everything before we mail it to a family or to a client. So if it's a teacher, we set up everything that we possibly can, including pairing of the Bluetooth, charging it, and then just making everything as easy as possible. So really reducing the response effort. And then having some alternative means of communication can be helpful. So in case of the technology breakdown, or if there are technological problems, we rely on other forms of communication like telephone calls. I'm just going to call you, or I'll show, if it's somebody nearby, we might have a face-to-face visit to set up all the equipment and run through it with them and actually have them practice while we support them. Now, that's not possible at a distance. And I have a doctoral student right now who actually provides behavioral teleconsultation alongside the Promise Wisconsin project. So that's in Wisconsin and rural areas. And she does everything at a distance with her families, and they're not necessarily the most technologically advanced families. They're SSI families. So she works quite hard at building rapport with them over the telephone so that when they run into technical difficulties, she can walk them through it and they don't feel as stressed out. Whenever we're really talking about remote communities, the first thing that comes to mind for me is what kind of internet connectivity do they have? So if you're talking about, some places in India, there will not be internet connectivity. And so we're really then focused more on telecommunication technology like smartphones that are more readily available for folks and that might not have the bandwidth to allow you to do two-way video conferencing, but that might allow you to do some didactic education around knowledge and advocacy as outcomes, or as an adjunctive to a face-to-face intervention. So there are no real easy answers for using this technology in truly remote locations or places where there's not good internet connectivity, but that's improving all the time.
Great. And Can you comment on, I guess, the general sense of social validity as it relates to these types of interventions, whether that's with a tech-savvy parent or a parent who struggles, or a caregiver who struggles, whether they're a parent or an RBT or whatever?
Yeah. So, in our work with teachers and families of children with autism and other developmental disabilities, we've used social validity questionnaires like we would typically use in single case research to assess their perceptions around goals, procedures, and outcomes. And we usually have a separate section around the use of the telehealth equipment and the procedures that are used. Our families tend to rate the use of a telehealth intervention highly. So whether it's a behavioral consultation or more of an educational consultation, our teachers and our parents rate it highly. However, in many instances, our parents are not receiving other services. So whether it's because their child has serious challenging behavior and they've been unable to locate a provider in their community, or they're in a rural area, or they lack childcare, or the parent has a chronic illness and they find it hard to actually participate in parent education sessions that are available in a major city, all those things are usually variables that our participants share. So we have started to program around that, but we find that the convenience of telehealth is one thing that allows folks to not be as concerned about the technical difficulties when they do occur. So whenever we think about telehealth, every time we do a social validity questionnaire with families, they say that it's convenient, that they get to stay in their pajamas, that they don't have to worry about childcare, that it's good to have access to a specialist. Many times they don't have access to a specialist for their concerns, to address their concerns. But then they also say that, yes, there were technical difficulties, or it was frustrating to use the technology, or sometimes it was hard to learn the use of the technology. But when you really ask them, did that sort of overburden you? It depends on how serious the presenting issue was with their child. So whenever we worked with families who have children with significant support needs, they say, absolutely, the technical difficulties are worth it. The inconvenience of dropped calls are totally worth it. I would do it again in a heartbeat. Every family should have this every day for the rest of their child's life. Mm-hmm. But if you look at families who have children with mild to moderate challenging behavior, for instance, I had a student recently complete a dissertation where she looked at families who had children with mild to moderate challenging behavior. And the families, we had a higher attrition rate for one, and the families were less happy, less pleased with the use of telehealth, and said they would prefer face-to-face. And we're not sure, that we didn't actually, experimentally evaluate this component, but I think it's a question about, there is a certain response effort to learning the use of technology. And we do need, as a field, to figure out how best to determine which families will benefit the most from the use of telehealth and which ones we should just use face-to-face. I also think there's sort of ethical issues around face-to-face versus telehealth, and that, parents really should have a choice. If we're talking about service delivery, it's important for families to be able to have a choice so that they feel like this is something that they're engaged in. Now, outside of applied behavior analysis, people have done a lot more around social validity of telehealth and have found that a variety of different disability categories, like cancer survivors or people that have diabetes, that these folks say that the use of telehealth is acceptable and that they want to continue doing it. And in some ways, the convenience part is the piece that outweighs the trouble that they might encounter with the use of technology.
I see. Where I am in New Hampshire, about 45 minutes northwest of us, is the Dartmouth Hitchcock Medical Center, which is a world-class institution, and people in kind of northern New England will travel there, whether it's for cancer treatment or some sort of specialized intervention or whatever. And I just, in having lived here for a dozen years or so, know of many people who make the trek, if as they call it sometimes, whether it's either going up there or going down to the Boston area or whatever. So I can certainly see how a telehealth model would alleviate some of those burdens and thereby generate high levels of acceptability, certainly. So
yeah, I will say on the end of the therapist side of things. So we've trained school psychologists who are in training to actually deliver behavioral teleconsultation, and what they have lower social validity than the parents. So in our studies, they're actually saying, I kind of rather do this face to face.
Really?
Yeah. And I think in part, and what we've sort of discovered is that behavior analysts know how to do behavioral skills training. But behavioral skills training is a little different to do over telehealth. Whenever we're thinking about the modeling component, especially, we can't jump in with the client and show, the interventionist how to do it. So if it's a teacher in their classroom, a behavior specialist might come in and say, the BCBA says, well, let me show you how to do this with Johnny. We can't do that with telehealth. So you have to be creative. You have to use video models. You have to use role play. You have to use virtual role play so that you actually say, I'm going to be the child and you're going to be the interventionist, and I'm going to act as though I'm the child. And we're going to pretend sort of virtual reality in this 2D dimension that we're looking at here. So I think that's the piece that troubles behavior analyst, is that they can't jump in and do the modeling, and that it's more difficult to build rapport. So it's a different skill set, certainly, to build rapport over telehealth than it is face to face.
Yeah,
I think.
I can see that would be really difficult, especially if you're trying to coach someone on some sort of prompt fading or errorless type of strategy that or if a learner is encountering difficulty with a particular lesson or whatever, sometimes you have to, at least in my experience, you have to get in there and kind of muck about for a little bit to figure out what the next step is and things like that. So I can kind of see where that would be a challenge from a clinician standpoint.
Absolutely. On the other side of things, like if you think about early intervention, we often say we want the early interventionist to be coaching the family member or coaching the teacher rather than doing the intervention themselves. But what we often see in practice is that the early interventionist is often pulling the child aside and doing the intervention. So even though philosophically we say, no, we're family-centered, or we're going to focus on the teacher's skills to build capacity in natural settings, we actually end up seeing the early interventionist jumping in, as telehealth provides a wall, so you can't do that. So that's been another positive side effect that we hadn't initially thought of, but that other researchers have talked about as well.
I see. So we touched briefly upon the topic of ethics and ethical considerations as it relates to using telehealth, but let's dive into that a little bit deeper. So what are some of the main ethical challenges that you see from the use of these types of consult strategies, and how have you guys, I say you guys, how have people who spend their time looking at this and things like that address them?
Sure. So the American Telemedicine Association and the American Psychological Association, as well as other professions, have position statements and guidelines on the use of telehealth. So we've used that to guide our use of telehealth, and that's always sort of evolving from our own research team perspective. But if you have a practice and you want to use telehealth, you should think about first of all, some administrative guidelines. Prior to actually having a telehealth encounter with your client, you should inform the parent or the teacher or the client themselves and educate them in real time. So whether that's through telehealth or through face-to-face contact, about everything that's going to happen in terms of the timing of service, how you provide privacy of their data, security, some risk. So what might happen as part of the intervention. So for instance, if you're doing an experimental functional analysis and you have an RBT there, but you want to let the parent know that if serious challenging behavior occurs, what's the crisis plan? So really having those important conversations up front about billing, of course, mandatory reporting, because now you are in the parent's living room. So making them aware, if it's a parent or the teacher, making them aware that you are now seeing more than you would, or as much as you would during face-to-face encounters. So just making people aware of that, because I think sometimes people forget that piece. because there are some legal issues around that, obviously. So we need to talk about confidentiality and some protocols. So what do I do if the internet cuts out? What's our next step? Or what if this doesn't work? Or at what point will we transition you to face-to-face services if this is not working out for us? How will we know when to transition to prevent some of those muddier issues that might happen in practice whenever you don't lay out those expectations early on?
Mm-hmm.
The other piece is around confidentiality, of course, and security of any data. And that actually pertains to both sides. So thinking about the parents' equipment as well as the provider's equipment, and making sure that, for instance, the provider's equipment that they use is encrypted. So an encrypted hard drive, encrypted files if they're saving information. So if you're video recording for later data collection or problem solving with another professional like a supervisor, making sure those files are encrypted, your computer is encrypted, and that it goes everywhere with you. You don't leave it in your car. So really, if you're a provider, if you're an agency, to have some really clear policies on the use of technology for telehealth, instead of sort of saying, yeah, sure, you can try telehealth,
Mm-hmm.
actually having some clear policies and guidelines on how to use it appropriately and how to use it ethically. So whenever we think about confidentiality, of course, HIPAA compliance comes into play, and making sure that your software is HIPAA compliant, and making sure that the parent side of things, that they're not inadvertently capturing things either. So you don't want them to accidentally be capturing information on a shared computer that they wouldn't otherwise want to share with other folks that are using that computer. So let's say they share the computer with their extended family members, but they don't necessarily want them to see the content of the behavioral skills training. Then you would want to make sure that their computer is not inadvertently sort of capturing that in some fashion. So those are some issues, as well as privacy. So whenever you think about privacy, I need to let the parent know who else might be in the room. So if you share an office, then you need to introduce the parent to everybody that's in the room and make sure they're aware of that. If you have a supervisor watching, they need to be aware of that. The parent should, or the teacher should, expect some sense of privacy. So they're going to expect the same amount of privacy as when you're having a one-on-one conversation with them. And although that might not always be possible, we want to make sure to do our telehealth sessions in as private as place as possible, like with a closed door and hopefully limited interruptions to no interruptions. From the parent side of things, we have some issues around privacy too. So let's say that the parent doesn't want extended family members on the video, but they happen to come into the room. So the parent needs a mechanism to stop the video, or to be able to just low tech sort of cover up the camera to protect their privacy. So those are some things that come to mind for me. It's quite a lot to really prepare for, I think, as an agency to roll out these guidelines, but thankfully there are some professional organizations to help us with that.
Can you remind me, you mentioned was it the American Telehealth?
The American Telemedicine Association.
Okay, telemedicine. Okay,
Mm-hmm.
and I will run this information down and have it in the show notes.
And then there's the APA guidelines, so American Psychological Association. SLPs have their own. BCBAs don't yet.
I see. I can imagine it's probably something that should be working on. Are you aware of any like ABAI working groups or subcommittees or anything like that's looking into this?
I'm not aware of any.
Okay. You mentioned HIPAA compliant software. Do you have any software recommendations or things that you've found that work well for you? And if I don't mean to put you on the spot, so if I can get this information,
Nope.
if you have recommendations off the top of your head, that would be great.
I like VC. VC works well for us. We're always concerned because we're doing behavioral skills training and much of our research, or when we're doing this for clinical consultation, we want to have we want to have two windows. So we want to have two windows that are recordable for our purposes. I want the window that shows the client and the child, And I also want to see the window of the supervisor. So this is important for practicing BCBAs, I think. If you are getting supervision from someone or you're supervising someone, you want to be able to capture both sides of that conversation at the same time so that you can review that later. Then VC works well for that. There's a multitude of ways that you can use to record your software, but VC has a built-in way to do that. So we've found that to be pretty useful and have had fewer dropped calls because we're a research outfit and we're not having HIPAA compliance kind of issues. We've also used Skype, but that would not be acceptable for most practicing BCBAs.
I see. Okay. And I will run down the VC software and put that in the show notes as well, where people can kind of learn more about that. So, wow, this is a treasure trove of information. I appreciate it. And again, I'm just kind of the deep dive into the gear is, I think is helpful. And of course, attending to the ethical considerations is obviously of paramount importance. So,
yeah, I think some other folks have used Google Hangouts before, and there's other software as well. You just have to be clear about the HIPAA compliance piece.
Are there other guidelines or recommendations for clinicians who are contemplating this that we haven't discussed already?
Mm-hmm. I think that just basically having those privacy and confidentiality pieces in place. Of course, there's also guideline. I mean, you have to consider the competency of the BCBA or anyone else who might be delivering telehealth. So whenever you think about the skills that are needed to deliver the consultation, those are the same skills that are needed to deliver telehealth, but there's a little extra with telehealth. And we haven't done a lot of studies around training people to use telehealth, but we want to make sure that people have basic rapport building skills over the use of telehealth, that they are aware of, mandatory reporting guidelines, because you're really in someone's living room and it's easy to forget that, I think, with the use of telehealth. I think those are the main things: privacy, confidentiality, the building appropriate guidelines for when to use telehealth, when to discontinue using telehealth, to ensure that we have some cultural competence and we're understanding of the family's culture as well. There might be instances where the use of telehealth is not considered to be appropriate for a particular family's culture.
I see. Sounds like, you sometimes hear the term soft skills thrown around, and I think there's even a workshop on that at the upcoming ABAI, if I'm not mistaken. And it sounds like you have to have really, really good soft skills to develop those connections in this kind of two-dimensional world. So those are important considerations. So, what other, obviously, we're new to this. Other people have already, kind of started this work. When I say other people, other professions and things like that. But as we're kind of embarking on this journey, if you will, in using these tools, what are some of the future directions for telehealth in the application of behavior analytics services or the implementation of behavior analytics services? Certainly, what are some research questions that you and your team are kind of looking at and things like that, and where do we need to go with this moving forward?
Yeah, so our research team is really interested in the effectiveness of telehealth behavioral consultation for individuals who have low incidence disabilities like Fragile X. So we're interested in addressing the need for more behavioral intervention research with a low incidence population where we don't have a lot of ABA research. So we are trying to make some inroads in that direction. In addition, we're really interested to leverage the technology in a way to enable us to look at treatment adherence or long-term treatment fidelity when the behavior analyst is not present anymore, and how we can use an operant model of addressing treatment adherence when we're gone. So really building upon that, enabling the technology to allow us to continue to check in post-intervention, in a regular fashion that's cost efficient is a way that we're trying to track that and trying to answer some questions around what happens when we leave. So we get the parents to acquire the skills for implementing their child's behavior support plan. The child's challenge of behavior drops to 0. It maintains there across the length of our intervention. And then we say, okay, well, we'll see you in a month. We'll follow up with you. Oftentimes in clinical practice, what would happen is that once we discontinue services, some of those children are going to have challenge behavior later on down the road, right? Some of them will maintain services. Some of them their function of their challenge behavior will change. The parent will experience resurgence. Something will happen, that requires some additional consultation. And one of the things that we're really interested in is that natural dip in treatment fidelity after your interventionist leaves, and the behavior gets better and you just stop using the strategies. You're not adhering as much as you should. We're really interested in what happens during that space and how we can affect it with behavior analysis. So we're increasingly interested in using covert mechanisms of observing behavior as well as following up with parents about their perceptions around why they stop implementing a certain intervention or what helps support implementation of an intervention in the absence of regular coaching or booster sessions. So with the behavioral teleconsultation study with young children with Fragile X, we're going to be following up with families for 18 months post-intervention and having monthly check-ins around those adherence kind of issues to try to get at what variables might be associated with continued use of behavior support strategies or discontinued use of those strategies. The other thing is really, for us, is really around addressing disparate access and thinking about how we can improve access to populations that haven't routinely been involved in behavior analytics services. And certainly this goes outside of developmental disabilities, but I can really speak to developmental disabilities. When we think about a population like Latino families of children with autism, they are diagnosed later. They tend to receive ABA services later, if they get it at all. And for instance, in our own state here, we just don't have a lot of bilingual, bicultural providers. And so whenever you think about BCBAs and how many we have in certain geographical context, like rural areas or areas where there's just a shortage of culturally competent specialists or bilingual specialists, then we really could use telehealth in a way to look at the effectiveness of telehealth delivered interventions by bilingual, bicultural interventionists. So that's another way that our team is headed right now, is thinking about how to serve Spanish-speaking populations or African-American populations who might otherwise not be served by BCBAs because of the lack of providers.
I see.
In our own local context.
Well, a couple of very laudable endeavors. Sounds like lots of areas for future research. So, wow, this has been like one of the most fast moving interviews.
Oh.
I really have I've got like pages of notes here. So and again, like I said, I'm trying not to get too excited about the tech piece of it, but that's interesting. It's an interesting component, but also how
interesting piece, yeah.
But also how it merges together with the access to treatment and the ethical considerations, and then of course the training and things like that. It's got a little bit of everything involved in it, so it's certainly a complex issue, and it's very much commendable that you and your research team are devoting precious research resources to looking at these things. So one thing I'd like to ask everyone before I let them go, Wendy, is we have a lot of students of applied behavior analysis who listen to the program, and also BCBAs who are just starting their career, embarking on this kind of in this new field. Do you have any kind of general parting advice for those at that stage of their careers?
That's a great question. So I think as a beginning BCBA, it's important to recognize that that you really are just at the bare minimum of knowledge, and that having mentorship continues to be helpful into later years of your career. As well as, so I would say encouraging people to continue that mentorship, not feel like they have to go it alone. Not everybody, I think, is ready straight out of their BCBA to open up shop on the corner, without some continued mentorship or at least some problem solving with a group. The other piece is really thinking carefully about the context in which they want to practice and the other providers that they're going to interact with and interface with. So I find a relative weakness of our BCBA programs is the lack of interdisciplinary teaming sort of practice that folks get. And BCBAs get a bad rap for not wanting to play with others, not to being rigid to other practitioners' recommendations. And sometimes within good reason, I think. But I think that having some additional exposure to working alongside other professionals, if you get the chance to work on an interdisciplinary assessment team or treatment team, or within a system like a school district leadership team, then those are really helpful in shaping that context that you will be in as a practicing BCBA, and give you some of those, I think you were referring to, softer skills around managing those interactions and making them as successful as possible for ultimate improved outcomes for people with disabilities.
Very cool. That's great advice, and that's why it's one of the staple questions I have in the interview format, because everyone usually comes up with something that's really helpful for folks to know, and that's good advice for, I think, anyone, regardless of where they are in the timeline of their careers. So, Wendy, this has been a great conversation. Thank you so much for joining me today, and hopefully we'll have you back sometime as we start to learn more about all things telehealth and telemedicine.
Yeah, this has been great, Matt. Thank you so much.
My pleasure. Take care.
Great fun. Thanks.
Hey, everyone. It's just me. I just wrapping up this episode here, and boy, did Wendy end on a really important note. The importance of mentorship and ongoing education are crucial to a good career in the world of behavior analysis. So I just wanted to take a second to underscore that, and certainly to thank you guys for listening, and to thank Wendy for coming on the show. So if you're out driving around and you're wanting to know more about some of the stuff we talked about, head on over to behavioralobservations.com, session 26, and there'll be links to all of the things that we talked about, some of the gear, some of the like the American Telemedicine Association, the Oregon Behavior Analysis Association too. So if those of you who are interested in checking out the behavior analysis scene out there, there's more info. And I think that's going to do it for today. I hope to see you guys at ABAI. And until the next time, we'll see you in session 27. All right, take care.
Thank you for listening to the Behavioral Observations Podcast with Matt Cicoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast. Thank you for listening to the Behavioral Observations Podcast with Matt Cicoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.